Good morning, everyone. Again, for the third time. Good morning. No caffeine yet? Good morning. I'm so excited today, especially this morning, because I'm talking. At least one person is excited. But I appreciate you coming in and supporting NAPS. Also, those that are online, I want to just shout out to Alden in UAE and the rest of the attendees. So my topic today, we switched a little bit. I hope you don't mind, but I'll be speaking on new diagnostics and therapies. I will touch on a few other items along the way, but hopefully this will be beneficial for you. Oh, all right. So the scope of my talk will involve a quick look back, a little bit of history, then the current therapies we have, the most common disorders, the challenges that we have, and how things are changing, and then, of course, options, compliance, and then I'll be showing some or explaining about the new therapies. Actually, let me get my paraphernalia. But before I begin, how many of you here have been in sleep for a year? 1 year. Anybody new in sleep? Come on, raise your hand. 1 year? Good. How about 5 years or less? 5 years or less? How about 10 years or less? Okay, a few more. And 20 years or less? Okay. 30 years? 30 years or less? Glenn? Oh no, he's over 30 years. Sorry. So as you can see, we have a variety of people who's been asleep. And so my topic today is to consolidate that idea, because of course there are new to sleep and there are those that had been in sleep for a long time, but the perspective now is changing simply because of the new technologies that are coming in. Just because you're new in sleep doesn't mean that you have a long way to go to understand sleep. And that's what I'm trying to get to. Okay. All right. So one of my three goals are understanding where we were and where we're going as clinicians, and then what the paradigm shift is happening right now and how the future looks. This clicker is not too friendly. I feel like Michael Jackson. All right. So in the meantime, the premise is, what are the most common disorders that we have? Of course, you have the upper airway, obstruction, insomnia, EDS, and movement disorders. Dr. Casiotis talked earlier, was mentioning about overlap syndrome or COPD that has both the upper and the lower airway obstruction. All right. And the current therapies that we have are these. The infamous CPAC, known in some areas in the US, or CPAP, or PAP therapy altogether. We have the oral appliances for CBTI, as mentioned by quite a few presenters yesterday. Then you have surgical interventions, and then pharmacotherapy. And here's a quick history session. It won't be too long, maybe 2 hours. All right, 1953 is the discovery of REM by Eugene Arzarinsky and Dr. Kleitman. Further on, discussed and researched by Dr. Guillemino and Dr. Dement, who are known to be the modern sleep medicine fathers, right? Father of sleep medicine. 1978 is when, 1978 is when the American Sleep Disorders Association, now the AASM, is founded, making the formal recognition of sleep medicine as a specialty. And then in the 70s is when the establishment of the first sleep disorder clinic was formed. And then in the 1980s, an introduction of the PSG, which is the actual comprehensive study now of sleep. And this a comprehensive sleep study tool combining multiple parameters or physiological movements, as we all know, okay, and such as the brain waves, the EEGs, EOGs, etc. Then in 1981, first clinical description of OSA was made. 1981. You're not gonna know. And so looking at the old systems, this one right here is not a torture machine. It's an old PSG and an EEG machine, right? As you can see there, those notches and swivels, those are how you actually manipulate the voltages and the frequencies and the settings. The bottom here, right. You can see that these are pens. Okay, these are pens. Underneath there's a little straw-looking thing, and they go into these vials with ink in them. So you have ink, you have this, it sucks out the ink, and then it goes onto the pen. Remember Rebecca's talk yesterday when she was talking about the deflection, the square wave calibration? That's why that was done, because you have to calibrate how the pen deflection goes, whether it's on the vertical or the horizontal axis, and also the time constant, okay? Now you can see why, all right? So it wasn't easy, and once you're done with your study, you are done. You cannot edit, you cannot change montage. That's it. If you fell asleep, if you're in RAM while doing the study, your study is stop. So anyway, then it ended up being developed into the digital format. So in the middle, that's digital format. Actually, when I finished school in 2000, and I was still working for another lab that we dealt with the paper machine. And so when I started doing things in the computer digital format, it was so weird, because at first we were doing things in DOS. Anybody know DOS? DOS? That's how we were changing, manipulating signal patterns and filters. You go to command prompt and you change. All of a sudden, you just click, 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 click. It was a weird experience because it was too fast. It was like, it's done? That's it? That means I can sleep more. And now you see some of the new PSG systems is super tiny, right? And it just requires a laptop. Now, outgrowing the lab, in the 1990s, there's an expansion of sleep medicine beyond the in-lab testing, and that's what we know now as your OCST or HSAT, HST, right? Out of center, home sleep testing device. This became more convenient and increased more access to the patients, because now sleep is growing. You're seeing more patients. Now people are becoming interested in getting tested, but when they see the machines and all the electrodes, they get scared. All right. So there was a study in around 2006, this device called micromesem. Micromesem study is now what we know as the apnea link. So at first that was used as a screener, simply because now the field is growing, you have more patients, But now there's a funnel, right? Then there's a lot of patients trying to come in to get diagnosed. And so a screener was created to make things simple, right? We used to use actigraphy. We used to use oximetry just to screen patients, because we want to make sure that before we schedule the patient for an in-lab testing, we have already have some ideas that, yeah, they might be positive. So we start to filter those that are truly negative, at least on the actigraphy and oximetry wise. But micromesom, the apneic ear, was a screener because it offered 3 channels, right? It has an oximetry, it has a flow, and then it has snoring. There's no belt yet to monitor effort. But then when it got approved after the research was done that it was actually comparable to an in-lab testing, it was well over 80, 86%, very close to how we can identify OSA. So it was then approved by the FDA to move forward as a diagnostic tool. Okay. All right, that's how it looks like. This one, that one looks like Night One or PDX. Anybody recognize that one? Is that a PDX or Night One? Interesting. Oh, sorry. All right. Now, in 1992, there's an approval of CPAP therapy for OSA. So this truly revolutionized the treatment options. It started the race also for developing more PAP modalities. Exciting event. And then 1999 was the introduction of the ESS, the Epworth Sleepiness Scale. All right, and these are some of your PAP devices. They're becoming smaller and smaller. Maybe sooner or later, it'll be integrated with your phones. And then in the 2000s, recognition of the link between sleep disorders and the other medical conditions such as CVD, diabetes, and obesity were recognized. Then in early 2000, you have more development on pharmacotherapy. FDA approval of modafinil for the treatment of excessive daytime sleepiness associated with narcolepsy was introduced in the market. All right, now how do we do things? Let's switch gears. With therapies, of course, when you have OSA, you go for PAP therapy, right? You go for CPAP, APAP, bilevel, auto bilevel, right? Okay? We don't really use ST mode for just OSA, right? Or ASV. Then insomnia, you have CBTI and medications. And then excessive daytime sleepiness, same way, medication, CBTI, and then movement disorders with medications. Now, what are the challenges with the therapies? One, and the biggest, is compliance. Why do you think compliance is important? Why? Why? Well, for one, at least in the US market, compliance is important because it's pushed forward by the payers, by the insurance companies. The insurance companies dictate what really happens, right? If the patient is not compliant, they will not pay for the intervention, for the PAP devices, okay? So everything is about compliance. It's a good thing, right? And then the other challenges are, you know, the therapies, CPAP, they used to be bigger, okay? They're big. At nighttime, you can use them as CPAP. In the daytime, you can use them to clean your room. Or take out the grass. And then it's also very human resource heavy. You need people. Before, when patients have been diagnosed, then they move to the distributor, or we call them the HME, DME, durable medical equipment, or home medical equipment. And they're the providers or the suppliers of the devices, okay? Now, they used to have respiratory therapists to go into patients' homes, all right? I did that job. I'm not an RT, but some states allow for non-RTs to provide the CPAP devices or the PAP devices, educate the patients, but we go to people's homes. And some homes I wish I've never seen. But it's very heavy. And so it was okay before, since they used to pay really well. And the insurance companies pay really well. And then you also have an issue with abuse, because sleep before was not regulated. Okay, so I'm explaining this now because this could happen here, right? Once sleep becomes more developed, once you see more patients, and then of course what comes after are the regulations. Before, any doctor can open up a sleep lab. In fact, I have one short story, 30 minutes. I saw this ad on the newspaper. Yes, newspapers were real. You touch them, hold them. Now it's just you swipe. Okay, but I saw this ad for a sleep tech. Oh, close to my house. Well, my mom's house. It wasn't mine. I live in the garage. But I got off that morning, had my jeans, rubber shoes, t-shirt, and I wanted to see where the lab was. And I saw it was nearby my house. I looked inside and somebody saw me and asked, "Hey, come in." I said, no, I'm just stopping by. But she forced me to come in. I said, no, come in. What do you need? So I told her I was a sleep tech and I saw the ad. Her name was Mary. I remember her. That was a neurology clinic. And she said, "You're a sleep tech?" She was so excited. "Let me call the doctor." I said, no. I don't want to present myself like looking like that, with just, but anyway, she called the doctor. She presented herself. She was wearing a very nice dress. And she was excited. Immediately, she said, "Come on back." So she showed me the EEG systems, and then she showed me the sleep system. Needless to say, she offered me the job right there. I took it. It was good money, because it was really good money back then. I started doing sleep for her a few nights a week. And then I asked her one day, "Hey, doc, we have some positive patients. Also, where's your report?" She said, "Don't you know how to write reports?" I said, "I have a template at work." So I used the template and she just signs everything. Anything I said, patient's crazy, put them on whatever, she will sign it. She just signed everything I did on a report. So after that, I asked her one day again, "Hey, doc, where do we send the patients for CPAP?" And she looked at me and said, "CPAP? What's CPAP?" So my vision got dark and tunneled. I realized then what she was doing. That was the abuse back in the early 2000s. Anybody was opening up a sleep lab. Anybody. Even those that don't know what sleep is. It's a long way. But I made money from her. Anyway, after that, I trained my buddy in there who was a barista. And now he runs a 10-bed lab. He even told me he wants to hire me as his tech. What an ingrate. Then we have issues also with coding and reimbursement challenges, because they were not completely designed, right? When you develop a market, so sleep here, once it becomes bigger and bigger, you'll have reimbursement. You will talk about coding a lot, because things will become more streamlined when you code. When you submit a report to the insurance companies, it will be just in codes, okay? And that will have explanations on how things will get reimbursed. And the biggest issue too is that everything was fragmented. You have neurologists doing sleep studies. You have ENT now doing sleep studies. You have pulmonary now coming in and taking over the whole business, right? You have psychiatry and everything else. Dental sleep has been around since the 80s also, but they were very smart. They stayed under the radar. So they were not regulated for a long time. All the other operators of sleep, the MDs, they became regulated ahead. And dental sleep was just coasting. What that meant was that the dental sleep practitioners, they get paid really, really well for a long time because there were no restrictions yet, not much regulations. I can tell you, like, there was a dental sleep doctor that I worked with before, and she was billing quite a bit, well over in the $7,000 to $9,000 per bill. That's pretty good money. Anyway, moving forward. Well, and now what's the changing landscape in sleep? Right? Within the last decade, there's several technological developments, right? And this truly made a big impact in how we see sleep. For one, wearables. Now, wearable sleep tracking devices, they're all over the place. I'm wearing one right now. I'm sure you are too, right? So these things, smartwatches, fitness trackers, they have accelerometers and they monitor everything, heart rate, even your location. They might hear you. I don't know. But these devices provide insights into sleep duration, quality stages. Many of these smartwatches now can tell you, right? Did you get REM or non-REM? Tells you. So very interesting. All right. I think when I click the signal, it goes to Mars and then back. There. All right. Now, digital health and newer HSTs. In the 2010s, integration of telemedicine and digital health tech into sleep medicine was started, allowing for remote monitoring and diagnosis of sleep disorders. Who does telemed now? Anybody do telemedicine here? No? So in our practice at USC, we see at least half of our patients telemedicine. So they could be somewhere. They could be in Mars and be seen. I think the one in Mars is Elon Musk, by the way. And in 2015, there's the introduction of the technology called PHAT, peripheral arterial tonometry. I have a sample. I'll pull it out later. It's right here. But this device is also for home sleep testing, and now these things are more convenient, even more so. All right. 2017, FDA approval of the first medication, which was indicated for the treatment of EDS in narcolepsy patients. 2018, getting closer to us now, was publication of the American Academy of Sleep Medicine's clinical practice guidelines for the diagnostic testing and treatment of sleep disorders. And then there was COVID. Killed my business. That's another note. And then 2020, there was a growing recognition of the impact of COVID-19 on sleep patterns. I think it was Dr. Hibunada that talked about COVID-somnia. Very interesting talk. And in 2021, advancements in wearable sleep tracking devices and smartphone applications for sleep monitoring and management were introduced. In fact, I think Samsung just recently released their new app. You guys heard about it? They have it on the Galaxy Watch, but it's an apnea tracer app. Actually, it's a pretty good app. I was once a part of the clinical team that looked into the PSG and compared some of the data. Okay. All right. More options, answers, and compliance. All right. This is the new era, right? From the wires now to unwires. Now everything is starting to become different, even not just on the size, the look, but how things are managed and implemented. All right. And more research that are going into genetics. There is an ongoing research on genetics, neuroscience, and physiology of sleep. So as the development of personalized approach to sleep medicine and patient care continues. There's some, one of the doctors yesterday, I think Dr. Say mentioned about, now is more, everything is patient-centric, so everything is individualized. The other presenters also mentioned that. Everything is individualized. It's designed for you. I think Dr. Lay also mentioned same thing. So it's not just one all be all, it's not generic. Everything is very much specialized for you, right? Okay, and there's more genetic research that looks into the biomarkers. These ongoing research into the genetic basis and biomarkers of sleep disorders aims to elucidate underlying mechanisms to identify at-risk populations and develop targeted therapies. And of course, the infamous AI. Every day, everything's about AI, right? Even my car, I'm driving and of course, you're not perfect. You're not always in your lane. I wasn't texting though, right? I was just watching a movie. But you get off a little bit, it pulls the steering wheel. It moves my steering wheel. It's scary. And now, in fact, I didn't mean to digress, but there's more technologies that are going to be built into the paint, right? Into the road signs. There will be sensors on the road so that the self-driving cars will be even more efficient and effective. Anyway, back to sleep. Now, artificial intelligence and machine learning are being increasingly utilized to analyze large data sets. Okay. And from sleep studies, identify patterns, like Glenn mentioned yesterday, pattern recognition. I guess sooner or later, Glenn will be AI'd. And also this assists with the diagnosis and management of sleep disorders. There are AI-driven tools that have potential to enhance the accuracy and efficiency. So accuracy and efficiency of sleep disorder detection and treatment or the decision-making. It's quite scary, but for those who are not trusting this yet, right? But we have the AASM supporting this now, right? AASM very supportive of the AI development in scoring. In fact, they already have announced the recommendation for, I think, ENSO data or approval, ENSO data and Somnolizer. Somnolizer has actually been around for a few years. It's with Philips. But before, if you want to use it, you pay. It's like $10 per study. Don't quote me on it, but I remember hearing about Somnolizer. So if you think about it, like there's so much data now, so much data. And so these AI and this machine learning, they study. But when they study, they exponentially increase studying in just a matter of days and months compared to human beings. So they have gazillions, trillions of data that they can sift through, they can go through super quickly, okay? So as you can imagine, the landscape is definitely changing. You know, we talked about the heavy human resource type of sleep medicine that we have is changing. You can see it now. There's many labs that closed, right? In the United States, there used to be thousands of labs, and now they start to close down, right? Not only because of AI, of course, but yeah, it's a big part of it because the home sleep testing devices, they can even auto-score, right? Of course, we have to validate it as clinicians, but they can. You're not talking about 0 or 50% capability to identify hypopnea and apnea. No, it's higher percentage than that. These devices are very, very smart, and they only get smarter by the day. All right. Now, digital therapeutics. There's also the development of digital therapeutics. phone apps, web-based programs for the management of sleep disorders, and has expanded the treatment options. These digital interventions may include CBTI, relaxation techniques, sleep hygiene education, and guided meditation. And this provides patients with accessible and personalized support. Have you guys done the Calm app? Calm app. It's embedded into my my Outlook. So after a few hours, it will ping me, Kim. And they'll give me an option to do it or not. And I do it. I don't use it to take a nap at work. I'm just meditating. So if my boss walks in, I'm just meditating, even though I'm snoring. So it's quite interesting how things are even becoming more personalized, but are now accessible, not just in the clinic or clinical areas, but also at home, right? And telemed and remote monitoring, and these are the integration of telemed platform and has facilitated remote consultations, follow-up visits, etc. Patients can now access from the comfort of their homes, leading to improved access to sleep specialists and continuum of care. Does this sound good or not? Do these sound okay or no? Can you hear somebody say okay? Nobody will get mad if you say no. So just with everything, there's pros and cons, right? What do you think is the cons for telemedicine? So yes, you have access to care. But by golly, some of the patients, when we call, they're ready. They're not even dressed. Like not dressed. Very inappropriate. Okay. Some of them driving. Come on. You can't drive and then be seen by a doctor. But so things have to be regulated again and again and again. Okay. So there's always pros and cons. It did increase the access to care and personalized medicine. There's not much wait. Imagine you have 100 patients. You want to see them today? Okay. All right. Now there are even robots. Robots has an iPad or a tablet, right? Now I say iPad for everything. Just like saying, can you get me a Colgate instead of saying toothpaste? Or I want a Coke that's orange. But now they have these robots in some clinics. They exist now. And these robots will go see a patient, right? Or will go to the doctor and the other patient on the other side. So the doctor could be somewhere in Mars or in Haiti, but they can see the patient because this capability is now becoming to not infiltrate, but to become widely used in the market of medicine. Now, before, it was mainly the primary care physicians that see a lot more of these patients. Now patients can get seen more into the specialized care, such as sleep, right? Now, what are the choices for diagnosis? Before, as you saw, this big, bulky things with pens and wires and sensors. Now you're talking about little things, little gadgets. These are some of the diagnostic tools. Can you imagine that? These are diagnostic tools that can identify apneas. And some of them can identify central apneas. Some of them can identify oxygen desaturation, snoring, central. It's quite crazy. Let me show you a device. For those interested, this is $3.99. Oh, give? Oh, 3,000. My price increase. More demand, higher the price. So I don't know if the online people can see, but this is actually brand new. The rep showed it to me. I gave him a donut, and he gave me his sample. What do you think is this? What do you think is this? There's something you balance? This is a home sleep device. So you put it under the chin, you tape it, and you go to sleep. So it will monitor oxygenation, will monitor AHI, it'll monitor REM versus REM, because it senses also the muscle tone of the jaw. Pretty crazy, right? What happens in REM? Glenn asked yesterday. What happens in REM? Yeah, so muscle tone drops and maybe apneas occur. When apneas occur, patient wakes up, the tech wakes up too. But imagine this thing. It's different when you see it in slides versus you see it in person, right? I feel like I'm marketing for them. But it's pretty crazy how far we've come. All right. Now that's one. It's another one. This is also brand new. This one's $12.99. $15.99 if I sign it. Like an autograph demo unit. So this device is a real device. I've used one. This is a new one. You put it on, you have put on your finger, and this goes on your chest, monitor effort. So you can have central recognition. Pretty crazy? That's not the craziest part. This uploads to the cloud. And the crazier part, you throw this away. You do. This is watchpad. This is one. Means used only once. And you throw it away. I will keep this so I can attend those parties with costumes. Now, that's real device. And then we have gone through other types. The one on the top, the next one. So not only are they small, but they use the cloud. So there's no going back to your lab or to your distributorship to download data. It's automatic, right? It's bizarre. So this thing right here, I've used it too. I went to a lab in 2022 for a few weeks, looking at the download of this device right here. This thing right here. Very tiny. But they actually pick up ODI, AHI. Pretty crazy stuff. This is bought by ResMed. This is a Belgian company. And now, right before I left the US a few days ago, there was somebody that connected with me on LinkedIn and has asked me if we can meet. They want to show their product. This product, right, is pretty crazy too. This is just a band, but it will identify the different sleep stages. And it also has an audible therapy, has sound, right? It won't be like, no. It will be like something more calming, Like maybe like I don't know what it is. You don't want me to sing. I will charge extra for that. But from this is not just this is already going into treatment, not just in the diagnosis part, right? All right. So, whoop. We were talking about the diagnosis, and now all right. And now let's talk about the choices for intervention. All right. Now, before we have PAP therapy for OSA, right? For obstructive sleep apnea, you use CPAP. You can use bilevel. When do we use bilevel? When do we use bilevel therapy with OSA? So you can use bilevel if they're non-compliant, right? They can't use CPAP, very uncomfortable, or you are increasing in pressure and they're still having apneas after 15 centimeters of water pressure. You can switch them to bilevel, right? You can also use auto bilevel. So these devices now, they monitor flow limitation, apnea, snoring. They can even monitor central. So these auto devices, their algorithms are very, very sophisticated, right? Now you have also more complicated patients, like complex sleep apnea or TEX, treatment emergent central sleep apnea. You have overlap syndrome patients. You have patients with neuromuscular disease and sleep apnea. You have one of the physicians mentioned yesterday was COMISA, complex insomnia. You have a lot of complex, like mixture of diseases or disorders. But the mode of intervention is also mandibular repositioning device, which I think Dr. Poisson will talk more about later. Then you have positional device that was mentioned yesterday by one of the presenters. And then, of course, surgical interventions. There's a whole nother list of surgical interventions, okay, for apnea. And then the new things now to pharmacotherapy. Does anybody remember the medication that has been moved forward to treat sleep apnea? If not, we'll Google it. But it's coming out. All right. Then you have implantable devices and neurostimulation devices. You have EPAP. Then this EPAP is not part of a device, a bilevel device. And then you have oral negative pressure devices. Let's see how they look. Three hours later. All right. This is the EPAP. No, this is not toilet paper stuff in the nose. This is actual device. So these devices, they are meant to create positive pressure or external positive pressure, right? So I've used one of them. Where'd that go? I've used one of them on the plane the last 2 months ago. 2 months ago, I used an EPAP on the plane. But let me move this forward. That one, this one creates negative pressure. So you have the INAP and winks, but you put this in your mouth like a mouth guard, and it has a straw, and this straw sucks very low pressure to pull your tongue forward, right? So you're sleeping with just a straw coming out of your mouth. Some of you might already do that when you sleep and eat. No, okay. This one, sleep and drink. Is there one? Glenn, is there a problem with the sleep drinking or no? I think the sleep drinking are just alcoholics. All right. Now, some examples are, there's also now neurostimulator or neurostimulation devices. And some of these devices, I'll show you an example. All right. And this is one of the devices that has been in the market for a while from UK. But this device looks like a Y, or in Tagalog, do you know tirador? Looks like that. It's like a slingshot. Looks like U-shape. You put it in your mouth and it sticks out because the one at the bottom right here, that's the battery. All right, that's the battery. And this thing, it has 4 electrodes. No, 4? 4 electrodes, all right? They are focused towards the genioglossus muscle. So they stimulate you. They give you a zap, all right? So you don't talk when you're doing this. It'll be a weird conversation. But it changes the voltage and it changes the frequency. So it starts at 3 hertz, then 10 hertz, 3, 5, and then 10 hertz, then 20 hertz. Okay? And then you can increase the voltage. You use an app to increase the voltage. All right? So don't do this when you're arguing with your spouse or with your significant others. But anyway, the point of this is it's a daytime therapy. You use it for a few weeks, every day, just 20 minutes, and it works out the tongue, particularly the genioglossus muscle. A clinical study was done in UCSD to show and to identify the types of muscles and what changes occur, right? From that study, it was with Dr. Malhotra. What he explained was that OSA patients' muscle are very strong, right? See, OSA patients, who's OSA here? No, I have OSA, severe too. But anyway, I have strong muscles. I mean, the tongue is very strong, but they don't last, okay? The tongue becomes flaccid, like soft, quickly. As soon as you fall asleep, yep, there it goes, blocking the airway. But then people without sleep apnea, their tongue muscles, the tissue fibers of the tongue, their tissues are not as strong, but they can last tonicity longer. So they can last. So if you compare into an analogy, one is a bodybuilder, right? And one is a marathon runner. The bodybuilder can be, or a sprinter. You've seen sprinters, very strong, powerful looking people. But then you have the marathon runners, usually very skinny, right? But that marathoner can run forever, from here to Mars and back, right? So that's the difference between the OSA and non-OSA patients based on that study. So this device, that's what it does. It will change the physiology of that tongue. All right, that was a cue. It says stop talking. But to think that it can reduce AHI, ODI, and snoring is pretty interesting. Okay. Now here's the device, and you can control it with your app. All right. Now, no, I won't answer questions yet. Yes. All right, sorry. It's taking a while to click. It's not moving. Okay. Oh, thank you. And now you have the implantable devices. So there are implants for OSA and there are implants for central apnea. But the device for the obstructive sleep apnea stimulates the hypoglossal nerve, whereas the device for the central apnea stimulates the phrenic nerve to stimulate and move the diaphragm. So both have different uses and indications. But to give you a perspective, patients can have a mask and a machine, or they can have this implant. No, this is so this is the implant for the central apnea, and this is the implant for the obstructive sleep apnea. Quite amazing how they're tiny, and then they treat our patients, right? Just like everything else, it has pros and cons. Some patients can tolerate the stimulation and some cannot. The main thing, though, is that it's already implanted under their skin. So when they want to get rid of it, it's not that easy. They're also very expensive. They're well over $35,000, $70,000. It's pretty expensive procedure. But in the United States, like this particular device, they are reimbursed by the insurance companies. All right, moving forward. Now, these devices, some actually start on their own, but some will have to be activated when the patient lays down. So this one is for the obstructive apnea patient. When they lay down, then they put this on and it activates the implant. The other one, as soon as the patient lays down, it activates on its own. So sometimes it gets activated without them wanting it. Now, there was a patient that we had an issue with because, for the obstructive apnea, what happens when the stimulation starts, your tongue protrudes. You go like that. So if the stimulation is too strong, and then that's how the action is, the mechanism. It's funny. That's why you only do that when you're sleeping. All right. And then this is the tiny part for the central apnea device. All right. This is the one that creates a negative pressure. You put it inside your mouth, and it creates a negative pressure to move your tongue forward. And then the same thing for this device. Those pros and cons. The salivation is always the issue because you have something in your mouth. So you tend to salivate. And then you have these devices. These are the EPAP devices. So this is the one I used on a plane. So you stuff it in your nose, and it comes in 3 sizes, right? You should do your own. You do your own sizing. Don't let anybody measure your nose. They might use their pinky. Okay, but you have 3 sizes here, and there's a strap that goes around your head. And then you just stuff it in your nose, right? So I was a little embarrassed because I was on a plane. And I admit I snore even standing up. My daughters will tell you that. But I was on a plane, I was falling asleep, I was tired. Because Glenn kept texting me. No, I'm just kidding. But I stuffed my nose and I put my mask on so they can't see it. I actually fell asleep for 4 hours straight, which was weird for me on the plane. So I don't know if it works or not, but I fell asleep with it. Interesting. And that's not me, but that's how I kind of look like without the hair. So how these devices work is that when you put it on, they have valves. When you inhale, the valves open so you can inhale. But when you exhale, the valves close, right? The valves close because you're forcing the air out. So when they close, it creates the pressure towards the back of your throat. When we ask the rep, how high of a pressure is that? Because we've never tested it ourselves, but they claim to have at least 8 to 12 centimeters of water pressure. Pretty high, right? So it'll be nice if we can, test it out more. And this I've done titrations with. So this is similar to the other device, but this one used to come with a cannula. The ones for the sleep lab, it has a cannula here connected to both, and then the cannula joins and ends up on a lure lock, right? It looks like a lure lock, and then you can attach that to your pressure transducer sensor, so you have flow, so you can see the flow pattern. And we used to do a split night with it, and there are patients that reacted positively. They have lower AHI, some snoring were reduced. But that one, we've actually tested it. The other one, no. The problem with this is you have to buy this. It's a sticker. So you can't keep reusing it. And you can't use super glue. Then it'll be permanently in your nose. It's not going to look nice. Are you all okay? Still awake? Okay. I'm about to get quiet now. I'm almost done. All right. See this right here? This is what I was talking about. So we were able to test if it was working or not. Because the first part of the study is without the device, and then the second part with the device, and we have the thermistor. You can just stuff the thermistor in there, or you just stick with the PTAF flow, and you will see, and you can compare the diagnostic portion versus the one with this EPAP device and compare the AHI or snoring. All right. Now there are more innovations like the beds and mattresses. You have sleep monitoring, smart beds and mattresses, and they have embedded sensors and technologies within the mattress itself, right? They can identify body movements, positions, respiratory patterns, but they are not, from my understanding and from those that I've looked at clinical study-wise, they're not out in the market. I don't know one that's already publicly or being used right now. I think there's still some ways to go, but this technology they have started developing this years ago. Minimum 10, 15 years, they've already started trying to develop these things, right? Now, smart beds, they have embedded ballistocardiography. And together with network connectivity, signal processing, and machine learning, they detect heart rate, breathing rate, and sleep versus wake states. I see the sleep test getting sad. Don't worry, we still have jobs. Okay, I started practicing how to dance for future change in careers. Cultural dance. Okay. Now, why is there a need for new therapies, right? Because we talked about it earlier, the issues with compliance. These therapies have pros and cons. PAP therapy, the attrition rate, people that quit PAP therapy is still up there. Minimum 50%. There's a lot of clinical studies that will give you different percentages. But for the most part, we're not at 100%, right? We're not even 80% compliance with PAP technology. So it's not going to change soon. It will just probably get modified, more sophisticated, better, more comfortable, right? But the issue is compliance, simply because if this market here develops and it becomes regulated, then you have the government paying for it or the insurance companies pay for it. Insurance will be your next big activity, right? Right now, you're cultivating sleep, the knowledge of sleep, the diagnosis, the interventions, or the treatment. Later on, it will move towards compliance, regulatory actions as you develop your market in sleep. Now, effectiveness of these new therapies is still too early to tell. Some had been around, like some of these devices have been around well over a decade, and they just now penetrated through the market and started being sold, right? But clinical studies are available, so they do have studies. Some are not meta-studies, like the one I mentioned to you about the tongue physiology, right? With the intraoral neuromuscular device, they have that one study has 20 patients, so it's not a big study, right? But they have more. They have more clinical studies. FDA approved. Now, there are more devices outside of the United States, but to go through and get into the US market, it takes a long time because of FDA approval. Yeah, they have to go through a very rigorous pathway to get approval and get into the US market. So there are definitely devices out there that we haven't even heard of yet. They're just not being used in the public market yet. And then there's the issues with insurance companies. So I do mention insurance companies because this will affect how we practice as the bottom line. We are all clinicians here, but we are all affected by the insurance companies and how they deal with our patients and reimbursement and all that jazz. Okay. And lastly, still requires pre and post installation studies. What does that mean? Right. So when you put the patient, or you get the patient diagnosed, and then you put them on a new therapy, it's not as easy as that. Right. The pathway is that usually you put this, you get the patient diagnosed, then they go on PAP therapy if they have OSA. If they fail, then you have the option to use another intervention, right? So it's not just getting the patient diagnosed and directly into a new therapy. No, there's regulatory compliance that needs to be met. All right. All right. Now, pros and cons, just in a nutshell, we've already discussed. The pros, of course, are new options for non-compliant patients. Before, when your patient cannot comply with, say, PAP therapy, because OSA patients are our biggest number of patients. They envelope the majority of the patients we have. Yes? But when they become non-compliant to PAP therapy, many fall through the cracks. They're not seen anymore, or they will not go back. They won't go back to the doctor and say, hey, can you still help me? Can you still fix me? I can't deal with this, right? Many patients just, I can't use this machine. I just use it to keep my door open or dry my car, right? So with the new therapies, there are more options. Insurance now have accepted many of these things. Some are still cash pay. So in this country right now, everything is still cash pay, right? But it will start to change because some of the other countries like Korea, Philippines, at least the insurance companies and the government start to help pay for the testing and also the diagnosis. It's meant to happen, right? And then because of that, you can capture more patients and put them into another type of therapy to try to help them. And sometimes helping the patient doesn't mean you drop the AHI to 0, right? It's even impossible to drop the patient to under 5 if their AHI is 200. or 150 or 80, right? If you drop the AHI to just a good 70, 80%, that patient's already giving you gifts, all right? Because they will feel a difference when they get into therapy. Now, simple, even if surgery is required, and long-term physical adherence is required. But the cons, as I mentioned before, this 100% compliance is still unsure. If they are placed on a new type of therapy, will they be compliant? And some are not, right? We've had patients that were OSA, we put them on implanted device, and a few months later, they don't want it. It's too much, too strong. So, our doctors will try to reduce the stimulation, but then when you do that, their AHI creeps up, goes up, okay? Then surgical intervention requirement, unlike PAP. In surgical treatment, there are many options, but not all of them are paid for by the insurance. And then, of course, there's the risks, right? These devices, especially implants, they have batteries. They do have strong evidence that they are safe, but still a con, right? And then long-term studies are still not available. All right, let's go. There. All right. Now, what are future expectations with these new therapies? Self-assessment with app-based monitoring, increased patient engagement. So for the most part, our patients, just with PAP therapy, right? Do they use the app here? In the US, all the different manufacturers, you have an app. Everything is app, right? You can check after you use your device the night before, you can check how's my OSA? Do I have any residual AHI? Did I use it for longer than 4 hours? So the patient themselves can see how they use it. And when patients are engaged, they become even more compliant. Now, increased convenience, patients and clinicians alike, payers and DMEs. Really, these technologies are meant to make things easier, right? So there are negative consequences, but things are faster. You can use this little device, you put it under your chin or you put it on your finger, and then the following day, that goes to the cloud, not in the sleep flight, goes to the cloud, that the doctors and the DMEs can see, right? And so that reduces a lot of traffic. It reduces a lot of human interaction, but also the duration of the diagnosis to the therapy, to the compliance, and to the management is all become really, really short. Then you have patient centricity with AI use. Because of so much data, everything now is personalized, very personalized, right? I'll be surprised sooner or later when you pull up your apnea app, oh, AHI is 0.3. You can also buy flowers for your wife because it's your anniversary tomorrow. Right? So everything is integrated. That's my point. Everything is now integrated because of the data that's available. But then this data is about that person, right? Not all of us require the same pressure. All of us have different requirements. All of us have different needs. And then the clinician's roles as guides and regulatory and less management. So my point here is that for us clinicians, techs, our roles are definitely changing. It's going to change. It already has started, right? We will be moving more towards the education, the compliance. We will be monitoring things because right now, somebody can stage, somebody can do this, somebody can do that. So what are our roles then, right? So our roles are changing. The most important thing is that we prepare for that. We prepare for that. There are more credentials coming up. There are already additional credentials for the techs, right? You have the PD, have CCSH, and soon you'll have advanced titrations. And these are all credentials. Because, why? The techs will still have work. simply because the main group of patients that are affected with these new technologies are, when it comes to patients, are the mainly OSA patients. So those with comorbidities are still going to be in the lab. And some patients, they might present in the beginning with obstructive apnea. But once they are placed on therapy, they show something else. They might be having complex sleep apnea, or they might have insomnia with PAP. So who here has done MSLT and patient is on PAP? We've done it. It's weird, but yeah, things are going to change. All right. Any questions? Yes. Yes. So when we do titrations in our labs with these devices. So they always start with low voltage, and then they'll wait till the patient is asleep, because you have to adjust it, just like doing with PAP therapy. When you see the apnea, the events, you start to increase. But it's not just increasing one voltage at a time. You know, they have different algorithms. We have a rep here that belongs to that company, and they can explain even the more detailed technique patient is sleep. And so, yeah, the other one, the oral appliance, that's used during the day. I mean, the intraoral neuromuscular device that stimulates the tongue, that's used during the day. But you use it every day for over a month, and then you're supposed to see the effects. We have had patients that say they're snoring and they feel better. And so some patients will take longer than others. Thank you.